Thanks, Rachel, and thanks for the organizers for having me. There's a lot of PIs here that I really enjoy reading their papers, and it's just really humbling to be presenting to such a great audience. So, yeah, thanks for having me. So, my name is Bubba Brooks. I'm a graduate student in Joel Banfield's lab at UC Berkeley. Today, I'm going to talk about hospitals. And just to orient you to my slides, at the top, there will just be either the main question or the take-home message for each slide to kind of orient you to what's going on. So why hospitals for room-occupant interactions? Well, hospitals have a unique cohort of occupants, namely that they're immunocompromised or receiving lots of antibiotics, or in the case of our studies, they are babies that are immunocompromised and receiving lots of antibiotics. And the microbial community is largely lowered because of the antibiotic treatment, and so we believe that any microbe that makes their way on or in them potentially could have been sourced from the room, and it's much easier to detect something like that than a healthy adult in their home, possibly, because there's just much more background to kind of parse through. And then the other thing, the hospital microbiome or the hospital building itself is unique because it's very well engineered. The building envelope is engineered to control humidity and temperature. We control occupancy in most of the hospital. Only certain people can go certain places, and it's cleaned really regularly. So it's a really interesting system to do experiments in. And then, of course, we care about hospitals because of infection. There's a high infection rate, hospital-acquired infections. 1 in every 25 patients will acquire a hospital-acquired infection, and it costs the U.S. roughly $30 billion a year to manage, which is a good chunk of change. And since 2004, many states have adopted a mandatory public reporting, and infection rates have gone down, but we still have a long way to go. And that's what this slide is indicating. So this is a hospital in Australia that they were demolishing, and before they demolished it, they did a 2-step terminal cleaning with 500 ppm chlorine treatment. Scientists then came in and took a bunch of samples of different building materials. They put them in their lab for 12 months at room temperature, and then they did a bunch of experiments. They did a bunch of 454 sequencing and found many escape organisms. I'm going to talk about escape organisms several times in the talk. These are Enterococcus, Staph, Klebsiella, Acinetobacteria, Pseudomonas, and different Enterobacteriaceae microbes that are common in hospital-acquired infections, oftentimes have multi-drug resistance, and frequently get into babies, at least in our cohorts as well. So they found lots of escape organisms. 52% of their samples were culture positive for multi-drug resistance, and they confirmed viability in many different ways, but one of them is displayed here as a micrograph of live dead cells. So the red, you can see there's lots of dead cells on this equipment box, but there's lots of green cells, which is living, and red cells are dead on the entry door, the main entry door as you walk into this particular intensive care unit. So once these polymicrobial biofilms become entrenched in building materials, despite all of this rigorous cleaning, they're really hard to remove. Okay, so I was tasked today to try to find general themes in the hospital microbiome field. So going back to one of the first studies, it's a Spanish group in 2012, did a bunch of 454 sequencing in a hospital, asking a fairly simple question: are there differences in different parts of the hospital? So they compared the general access hallway to the intensive care unit, and the main finding was that there's a higher bacterial diversity in the hallway than in the ICU, which makes a lot of sense, right? The ICU has restricted access, it's cleaned regularly, where the hallway is the opposite. Hewitt et al. In 2013, one of the things they found, I think Rob or somebody had a source tracker plot in one of their talks, but this is essentially 16S data piped through a source tracker software that tries to predict where microbes come from on the surfaces that you're assaying. And so, for example, human skin very likely populated this supply drawer in this incubator, as well as these handles and things like that. So the take-home message, one of the take-home messages from this paper, were surfaces in the hospital, the microbes on the surfaces are largely sourced from humans. And then we've talked a lot about cleaning, or I did in my background, and several other people have. Bokulich et al. A lot of people have done culture-based stuff on cleaning, but this was one of the first times to use qPCR estimates in a hospital. And not surprisingly, when you compare before and after qPCR assays of cleaning, you get a roughly 20% reduction in bacteria, and a little bit less, their p-value was a little bit weaker, but a little bit less in fungi, but cleaning removes biomass, which is not surprising. But one of the other things they found in their study, they asked how does the community shift before and after cleaning, and they found 3 distinct clusters. The red dots are before, blue after cleaning, and then the orange dots, which span kind of laterally on the bottom, were infrequently touched surfaces and surfaces that don't interact with the infant too much. So they found 3 distinct clusters. So cleaning reduces biomass and it also shifts the community before and after. But one thing they pointed out is that many of the escape-style organisms still remained, and some of them were reduced in relative abundance, and then some of them weren't. The Enterobacteriaceae family in this study were largely unchanged before and after their cleaning treatment. And then one other thing I'll point out about hospitals and the unique challenges in hospitals is that they're very low biomass, and there's been a big call to arms in the microbial community field to do a better job of doing good controls and really paying attention to your negative controls. And the NIST talk earlier, they're talking about spiked in communities and things like that. And so controlled positive controls, but we also need to be paying very close attention to our negative controls as well. A lot of the variation in the data is explained on this principal component 1 axes, where 40% of the data is driven towards the bottom right. And I think a lot of this may be due to these Schwanel and Halomonas, which hang around buffers that we use in extractions and things like that. So just to review and to compare and contrast what we've learned so far, hospitals compared to other building environments, humans are overwhelmingly contributing to the indoor environment. There are differences across zones, so the hallway is different from the ICU. So you might have these discrete pockets throughout hospitals. And then cleaning and low biomass make the hospital environment a really challenging environment to study. Okay, and speaking of biomass, we've done lots of biomass quantification. This is hopefully data that will be published soon so I can graduate. But so what you're seeing on the x-axis are different environments in a hospital that we've been studying, and then the y-axis is 16S counts assayed by digital PCR, which is like qPCR. And the take-home message on this slide is that you see 3 to 4 orders of magnitude difference in the hospital. So just let's walk through some of these environments. If you look at things that are frequently touched by the healthcare provider, things like surfaces and mice to log infant data, the handrail, isolate knobs, they have roughly the same bacterial concentration or biomass. If you look at sinks, where there's water, there's typically lots of life. It has one of the highest biomass quantities in the room. And then surprising to me was if you take the floor at the main entrance and compare it to the floor right in front of the infant's incubator, I would have guessed that the main entrance would have higher biomass because there's more foot traffic, but that wasn't the case. There's higher biomass right in front of the infant's incubator because there's more concentrated occupancy there. The nurses come every 3 hours to maintain the baby, clean it, feed it, things like that, whereas the general entrance is just transient occupancy. And we see that also reflected in the bioaerosol samples we took, where there's a higher biomass in the infant's room, where there's more concentrated occupancy, as opposed to the general, the main entrance, where there's more transient occupancy. Okay, so to add on to our conclusions, I would say occupancy is a massive driver in the hospital environment, especially the more critical wards like the ICU or the NICU. Okay, so making a hard transition away from 16S quantification, and a lot of the stuff I presented with 16S data, our lab's really interested in assembling genomes from metagenomes, and how is that applicable to the built environment, and what conclusions can you glean from that? So what this study is these are babies right here, 1 through 10, and then their day of life before that. And so we're comparing fecal samples here, but again, we think fecal samples may be somewhat of a decent proxy for what's going on in the room, or how microbes are distributed in these environments. And to walk you through what you're seeing here, here's a Clostridium parapetrificum genome, and we see this genome appearing in infant 2. We see this genome appearing in infant 5. It's treated with antibiotics, acquires a different strain of parapetrificum, and then reacquires the same strain. Infant 6 gets this strain, also has another strain, and then infant 8 gets this strain. And so out of the 6 species I show you here that have many different strains, you can see that in the red, 3 of the 6 have strains that are shared by infants that are co-housed in the same place at relatively the same time, or at least in the same hospital, same place at the same time. And so that would suggest that the built environment has a really strong impact on these infants. That would be misleading. This is an excerpt. So if you zoom out to this study, we reassembled genomes for roughly 150 strains that were isolated from 10 of these infants, and only 4 were shared across these 10 infants in this cohort. And so to add to our list of the summary list, there are a multitude of strains available to colonize infants in these environments, and not many of them are shared. Not shown here, we do have several strains that are really good at persisting in hospitals that you can find over multiple years, which is a topic for another time. But I think that there are also numerous strains in a home or in an office, and maybe in homes there might be more strain sharing because you're eating similar foods and maybe have more similar life histories than the baby over there. Okay, and then it was unclear to me going forward how the breakout sessions were going to happen, and so one thing that I was thinking of is in the field generally, if I had to classify the way that a lot of these projects have gone, we've focused on reservoirs, who's there, how do they change over, or what microbes are there and how do they change over time. Dispersal, heard a lot of particle scientists in previous talks talk about transmission, epidemiologists talking about dispersal and like hand-to-hand transmission. And then I use the term engraftment here. Maybe if you're an ecologist, colonization would be a better term. But thinking about, I think we're on the edge of maybe suggesting ways to introduce like smart probiotics. We certainly are in certain diseases, and maybe that's something for the built environment field to think about. But we still have a long way to go to, in an intelligent manner, stick a probiotic on some drywall and anticipate how it's going to affect occupants. But yeah, so this is just like food for thought to think about in the breakout sessions. Yeah, and so I do have a little bit of extra time. I prepared, I'll come back to this. I prepared some distinct slides of where I think studies in the past could fit into these categories, just to kind of contribute more to the discussion later. So the concept of reservoirs, the end goal is intervention, whether it's in probiotics or diluting reservoirs, right? And so Kimmel et al., Jessica Green's group at the time in 2012 in ISME, they went to a hospital and they just opened the windows, right? And they wanted to see what happened. And when you open the windows in a hospital, if you look at outdoor air in the blue and you compare it to indoor air, the hospital ward that had the open windows had a mixture of, the community looked like a combination of both of those things. And if you assay the microbial diversity, the diversity increases as you approach an outdoor air-like state. Now, what's healthier and what's not for immunocompromised patient, I think there's a lot of testing to be worked out there. But in a lot of studies looking at microbial dysbiosis, typically diversity is a good thing. And then this was hijacked from Brent Stevens at the last meeting. And so I'm not going to talk too much about it because he gave a really good talk. But this is from the Chicago Hospital Microbiome Project. And what they did is look at a hospital before it was built, during, and after to see how quickly the hospital acquired this iconic hospital microbiome-like state, which is basically like a skin cloud. And the reason why I bring it up is just to circle back to the beginning, is that if you take the approach of being proactive in observing and maintaining these ecosystems, maybe it'll be much easier to prevent these really hardy polymicrobial nasty bugs from embedding themselves into the building materials. And then lastly, this is a really massive slide, but I really like Jeff Gordon's work. He's doing a lot of really great work in the gut microbiome and trying to predict which strains are better at invading and displacing an established community in the mice gut. And this is looking at obese and lean mice and which strains in a lean and obese mice can invade the other and displace one. And so we still have a long way to go, but you can envision something like this impacting the way we think about either buildings and providing some type of magical cocktail to make occupants feel better, or just having an oral probiotic administered orally to, say, a baby to make sure that they don't get a hospital-acquired infection. Okay, and so, yeah, that's 15 minutes. So just to add to the wish list, I would say more genomes, more strains. I think there's a lot we can learn from strains and how they're distributed in the built environment. I'd say more quantitative approaches are needed, especially in low biomass settings. Better controls, NIST covered that really well. larger cohorts with more metadata, and then also piggybacking off of other projects. You know, probiotics are becoming such a big thing, and it'd be interesting to see, particularly in a baby situation, how far these probiotics disseminate in the hospital. Are there different environmental parameters that could change the efficacy of these probiotics? Just thinking kind of outside the box. Okay, so lastly, I'd like to thank Sloan, because they heavily funded this, and it's been a really fun project, and then Jill for tolerating all my shenanigans. Yeah, thank you.
Thanks, Bubba. Okay, last up we have Venkat to talk about the International Space Station, and then we'll move to the panel.